It has been a tough few years for Saskatchewan's healthcare system. Recently, emergency rooms in rural communities like Kipling and Watrous closed temporarily because there just wasn't enough staff to stay open. In Regina, the new urgent care center has had its hours reduced several times. And a recent review into physician culture in the city's hospitals points to what's being called a medical leadership crisis. But last month, the health minister said the number of people in our province waiting for more than 2 years for surgery is nearly zero. At the same time, though, the wait list for surgeries went up. It grew. The number of people waiting more than 1 year for surgery, though, dropped over 24%. Those numbers were from April 1st of 2024 to March 31st of 2025. They showed that 92% of people received surgery in under 8 months during that period. So what does all of this mean? Today on Blue Sky, we are talking about the pressures facing healthcare in this province, from staff shortages to strained systems and what needs to change. If you want to weigh in today, call 1-800-716-2221 or email bluesky@cbc.ca. Okay, so as we mentioned, residents in some rural communities say closures forced by a shortage of doctors and nurses have left them without access to emergency room services, forcing them to travel long distances in critical moments. We know in Kipling, east of Regina, the emergency room there closed July 4th, and they expected it to stay closed for 10 days. According to the mayor there, Patricia Jackson. Now, according to the SHA website, it did reopen yesterday, July 14th at 8 a.m. Mayor Jackson was asked if healthcare has been an ongoing concern in her town.
It has been. This is the first time it's been for the lab and x-ray, but we have, thank heavens, weathered a storm where we had two of three physicians that came toward the latter part of fall last year who have two of them left at the end of January. And so we've had one physician here instead of three, but that is rectifying itself slowly, and we were very fortunate to have coverage from some locums and some close-by communities that also sent some people here and there. What we need at the moment is some lab and x-ray technicians that want to come here. One of the things that has to happen, and I've talked with a good many people about it, is when we have people come, we're 90 miles from the city of Regina. And when we have people come here who are from other places in Canada or other countries, they have to come with some kind of knowledge of what a small community is like. We're not a big city. We're a community of just over 1,000 people. It's a different mindset.
That was Patricia Jackson. She is the mayor of Kipling. So let's get into it, shall we? We have a lot of ground to cover today, but today's guest says all of it is actually related. Stephen Lewis is a health policy analyst, and he joins us now in our Saskatoon studio. Welcome back to the show, Stephen. It's been a minute.
It has been. Thanks. Nice to be here.
So I want to start by talking about these recent rural emergency room closures in places like Kipling and Watrous. What do they tell us about the state of healthcare in rural Saskatchewan right now?
Well, you could substitute Canada for Saskatchewan and find the same thing. It's not the only province that has difficulty staffing rural areas, and there's an ongoing discussion about emergency services. I think the realities of how the system is unorganized are coming home to roost. I mean, there is no coordinated provincial health human resources plan that can actively distribute personnel to rural areas. Like physicians, for example, are entitled to set up and practice in whatever community they want, and if they choose the cities over rural areas, even if there might be lots in the cities and not very and very few in rural areas, so be it. It's also part of urbanization, healthcare. People with good training and credentials have a lot of options. Not many people choose to live in very small towns anywhere in the country. And rural Saskatchewan has been depopulating, and most of the towns have been depopulating for decades. So it's a bit of a perfect storm. Mm-hmm. And I guess the final element is how we frame the problem. I mean, clearly, rural and remote citizens are entitled to the best possible emergency services, but there are medical equipment and other realities that confirm that you can't look after serious emergencies in small places. You simply don't have the staff, you don't have the volume of work to maintain skills, you don't have the equipment to intervene in life-threatening circumstances. So in discussing what to do about it, all options have to be on the table. A first-rate medical transportation system is, of course, paramount. Helicopters, ambulances. You want the first responders, the EMTs, to be have as much advanced training as possible. And we may have to think realistically about the risks and the benefits. I know people who live in rural areas may be anxious about access to emergency care and so on, but realistically, there is always going to be a little bit of added risk when you live far from a city with a modern hospital, and there is literally no substitute for that, and there's no permanent way around that.
Stephen, I want to dig a little deeper into something you said off the top there, where you said disorganization, that it's disorganized and that we don't have a distribution system to get people where we need them the most. How would we fix the current situation in terms of an organizational structure that would make sense and that would help fill some of these gaps? Forget the lack of staffing, but how would organizing it help?
Well, I think the big question really is in the community-based care, primary care in particular. So hospitals, although we'll get to the Regina situation later, hospitals are an organizational structure. They have a staff structure, they have a certain number of positions, and it's organized, there's clinical leadership and so on. But since the beginning of Medicare, primary care has never been officially part of a system. It remains essentially a cottage industry, and it's very autonomous. And physicians have, through negotiation, secured the right to move freely or not move freely or not move to where a community's needs might be. So you have these chronic maldistribution problems. And then the second part of that is, even if you could organize it a little more formally, what do you think the minimum number of staff, and medical staff in particular, and nurse practitioners you need to have a consistent service? I mean, one of the problems that, as Mayor Jackson described, these happen all the time, and it's really no better to have an emergency service that is erratically open and closed than not to have one at all, because it's the uncertainty that causes the problems, and if there's no secure service. But back to your fundamental point, I think we have to start considering biting the bullet on primary care. If primary care is not part of the Saskatchewan Health Authority, the Saskatchewan Health Authority does not run primary care. It has very little to say about primary care. I mean, it has people, it has a division that's called primary care, but the reality is this is not a managed part of the system. For the personnel, it's certainly not managed in any significant way from a quality and safety perspective. It's a cottage industry, and you can't expect that 1,000 clinicians and little clinics making autonomous decisions about where they set up practice, whom they serve, how many patients that they're going to take on their roster, whether they have or don't have clinical hours after 9 to 5 and so on, To expect that all of those independent decisions are going to create a system where everybody has reasonable access is a pipe dream. And the evidence for that is we have never had more primary care doctors per capita than we have now, and we've never had more patients who don't have a regular source of care as we do now. So this is clearly not working, and there is frankly no way it's going to work unless we take another shot at organizing this like you would organize any other system, like you organize a school system. All the teachers can't practice in Saskatoon and Regina. They have to go where the jobs are. Mm-hmm. So if this is designed to fail, and it fails.
I did not realize we have more physicians than ever in the province. My guest today is Stephen Lewis. He is a health policy analyst. Stephen, it makes me a little speechless when we talk about the lack of organizational structure in the way of primary care. I don't know if I knew that or I didn't realize it, but I think my question for you is then, are specialists like a gastroenterologist or a plastic surgeon, are those part of primary care or are those part of the health region? And when you consider the disaster that referral services can be, where do they fall?
Well, if you're a specialist and you need to have at least partly a hospital-based practice, either you're a surgeon or you need the equipment and facilities to serve your patients, you have to have hospital privileges. They're not automatic, and so in a sense, it is somewhat more organized from that point of view. Although again, as the report on physician culture and Regina pointed out, there are serious problems there with recruitment and retention and so on. But yes, but there are specialists like internal medicine, pediatrics, and so on that aren't hospital-based, and it's with some differences, it's the same for them about where they practice, right? So you will get some specialists in smaller cities like Moose Jaw, Prince Albert, North Battleford, Swift Current, and you'll have general surgeons and so on because of the hospitals and so on. But yes, generally for any physician who doesn't substantially have a hospital-based practice, it's the same as family doctors. They go where they like. And of course, most of them, the ratio of how many internal medicine specialists you'd need per population, it's much higher. You'd need, several thousand per internist. So there is no local business that's going to sustain their practice in a town like Kipling or Watrous, so they tend to go to the cities anyway. And they will also be seeing more complex patients where it's often important to have other specialists to coordinate the care with. And as far as the referral system, there's a bit of anarchy there too. There are no organized channels where there's constant monitoring of the wait times to see various specialists. And, GPs will have relationships with specialists and they will tend to refer their patients there. In some cases, if you ask hard enough and you look hard enough on the website, you can certainly find out where wait times for surgery might vary. And if you're prepared to have it done in a smaller center, you can shorten it. But as far as the wait to see the specialist in the first place, again, that is almost entirely unorganized and a bit of a black box and a mystery. And the wait times may vary considerably to see one pediatrician versus another pediatrician, depending on how long they've been in the community, what kind of relationships they have with family doctors and so on.
Mm-hmm. Yeah, I know of an orthopedic surgeon in the city here who stopped taking patients because his wait list was so long and was trying to get a handle on it because he was someone that was so highly referred to. I want to talk to you about staffing shortages in comparison to education. Is it that we have an aging baby boomer population? Is that the problem? Are we cranking out more students than ever before? Where is the gap with the graduates and the education? Are they leaving Saskatchewan? Why don't we have enough people filling the vacancies as they're coming available? What's the gap when it comes to people coming out of school versus filling those vacancies and then patient load?
In a nutshell, most of the above. the number of graduates in Saskatchewan is pretty stable. It's around 100, 110. I forget the size of the medical school, which is bigger than it used to be. But Saskatchewan has been either at the bottom or second to the bottom forever in terms of the retention rate of our graduates. We are net exporters of Canadian graduates. So we rely enormously on international graduates, especially for rural areas. And that's a problem that is very difficult to do something about. Again, especially when you look at specialists or people doing residencies, if you go and do a specialty residency in a larger center, the chances of you putting down roots in the last place you were trained are pretty high. So, and as far as family medicine goes, again, everybody has options. And one of the responses in Canada has been, as we've turned out more and more and more and more family physicians than we've had historically, is that there are more who will just work part-time. Because
they can.
Yes, and for a very interesting reason. I mean, it's not just seeking better work-life balance and that the fact that for 30 years, where gradually more women have entered the physician workforce, and they do work somewhat fewer hours than men, but that's not really an issue, and that's not really a recent trend. What's happened is that in frustration and in the hope that it would work, governments have thrown large amounts of money at physicians. In British Columbia, for example, at the end of 2022, family doctors got a 52% raise. Now, the hope was, well, with this new lucrative fee codes and top-ups, it's going to attract people to family medicine and they're going to work longer because then they can make more money. Well, it's quite the opposite. A lot of them said, well, I can make my income target now by working a day less a week. So they do. So the number of family physicians who actually practice full-time, seeing a regular full-service roster of patients is pretty small. It's generally a minority. I mean, there was a study that I was part of in BC years ago. It was about 25% of family doctors practiced in that way. It's probably somewhat higher in Saskatchewan. But then they can also specialize a little bit. Like someone may say, I just like to do sports medicine. Mm-hmm. And I think it's much more fun than looking after frail older people who have complex needs and so on. So I will do that. Or, I'll do some of this, but then I'll have a Botox practice on the side outside of Medicare, and I can make good money doing that. Or I don't like to work Thursdays and Fridays. And there's no way to actually get a handle on all of this. And there's no explicit quid pro quo here that, if we're gonna put you through medical school, it's very expensive. We expect you to work full time. I understand why you can't do those things, but the reality is the physicians have a great deal of freedom about how they practice, where they practice, which patients to serve, which little niche areas they want to occupy. And again, inevitably, you are going to get a lot of gaps, both geographically and even in terms of some patient groups who are difficult to serve, who may have difficulty finding a family doctor. And on that latter point, one of the emerging problems is a whole lot of older patients who have been with their older physicians for decades. Those physicians are finally retiring in their 70s and sometimes in their 80s, and nobody wants to take over their practices. So all of a sudden you're starting to get orphaned seniors who actually need to be seen quite regularly. Mm-hmm. And so they have to rely on locums, or they have to rely on walk-in clinics, or using the emergency room for primary care and so on.
Which is terrifying when you consider the medication that some of these people are on and need to be monitored, right?
Absolutely. And again, there is no systematic approach to saying, for example, if primary care was owned by say the Regina district, or what used to be the Regina Health Region, but now the Saskatchewan Health Authority, would say, okay, who are the unattached people over 75 now? And you say, well, that's a priority area. Get the family docs and nurse practitioners, who should be used much more extensively as well. Get them together and say, all right, we have 300 people over 75 and we've looked at their records and 100 of them are at severe risk, we've got to find them a regular source of care in a week. And what's the plan, guys? And do it. But there's simply no way to do that now.
Can we fault doctors for choosing? I mean, they invested the time, they invested the financial money to become a medical professional. Can we fault them for doing what they want when they want?
You can't fault anyone for doing what they want when they want. If you said to me through my career, do your work any way you feel like it. And, as long as you can get somebody to agree to read your analysis or your report, the state will pay you for doing so. And we're not going to actually do much about assessing your quality or your efficiency. I would have loved that. Of course, I don't blame them. I don't blame them for being such incredibly successful bargainers over time. I blame government for making the same mistakes over and over again. And in some ways, I will say, I think the profession really needs to look in the mirror and at least co-own some of these problems. I mean, again, medical unions are the strongest unions in the country. They have way more strength than the Teamsters. And when you get down to it, I mean, they have a remarkable protective umbrella around their members, and they are extremely sophisticated and successful bargaining agents. Plus, it's an essential service, and everybody's afraid of them, in a sense, right? That we don't want to alienate the doctors because they will go elsewhere, which is always, and in Saskatchewan, of course, that threat is probably a little more real than it is in some other provinces that tend to be destinations rather than exporters. So no, I don't blame them, but I think we need a reset. And if we don't fix it, then you could double the size of the medical school. You could pay everybody twice as much money, and you still wouldn't solve the problems.
We are talking about the state of healthcare in Saskatchewan, the pressure that it is facing as different emergency rooms and healthcare centers close temporarily around the province on and off due to staffing issues. Francois Wrights is a longtime locum doctor. That means he temporarily fills in for another physician's position. It could be because of a leave, vacation, or staff shortages. He's the senior lead physician in the Rural Relief Program run by the Saskatchewan Medical Association. The program addresses continuity of care in rural Saskatchewan.
Well, I think we started to notice some changes, I'd probably say about 2018, 2019. Now, I think we've always known that we were going to run into at least a mass retiring of doctors because we have a significant number of particularly our family medicine or our family physicians who do fall within the so-called boomer category, right? So anticipated at least retirements. I think what happened was we got a big microscope put in front of us, which was the pandemic. And I think it was both a bit of a wake-up call as well as a catalyst for certain things. A lot of them reassessed their role within the healthcare system. They started to grasp the concept of work-life balance. Lots of individuals decided to retire early. And of course, the entire issue related to burnout, overwork, and expectations was then addressed. So what have I seen, at least within my practice? It's vast increasing workloads. It's not just physician shortages that we're seeing. We're seeing a shortage of a bunch of healthcare workers throughout. So my nursing colleagues, my pharmacy colleagues, my lab techs, etc. There's a shortage of everybody, right? It has become more difficult to get international medical graduates in, how they are licensed, how they are then put at least practice has changed a fair amount. So there are limitations from there. Our population has also changed, right? Canada's growth rate, I think, for 2023 was over 3%. You've got a growing population, and we're not meeting those needs. We've had issues with retention and recruitment of physicians, not only in this province, but all over. Efforts seem to have been focused more on at least recruitment at the moment. Trying to deal with work overload is problematic. Your hours are ridiculous. So I started at 8 o'clock yesterday morning. It was clinic. I've just completed a 24-hour emergency room ER on-call, and I'll be working till 5 o'clock today, right? So this is what a rural physician is doing. I think when addressing, the current issues, one shouldn't be having a look at providing adequate care now as an end goal. I think, looking at achieving adequate care for what our requirements are going to be 20 years from now. Like, that forward thinking really needs to be taken, into consideration. What we need is adequate staffing throughout. Physicians, nurses, lab techs, nurse practitioners, etc. We need the whole team. We need, in essence, the bottom of the pyramid. We don't need tons of managerial support or to be micromanaged, etc. We need the people on the ground. Okay, then those individuals need to be adequately remunerated for what they are worth.
That's Dr. Francois Wrights, a longtime Saskatoon locum doctor. He says some providers have made efforts to create healthcare stopgaps, but people are still finding themselves overworked. My main guest today is Stephen Lewis. He's a health policy analyst. Stephen, what stood out to you from what we heard there from Francois?
Well, a couple of things. First of all, he's right about the boomer age doctors retiring and so forth and the gaps. In general, he made some references to other kinds of health workers and that there's shortages elsewhere. But I think when he talks about 20 years out, I think there are things we know right now that we have known for 20 years. Primary care cannot be strictly physicians. There has been a lot of work in Canada done on the need for interprofessional care because the population is older, the needs are more complex, and there's no magic Marcus Welby physician who is going to be able to look after all of the needs of complex patients. So, are we organized to have polyclinics and interprofessional teams? And the answer is, with rare exceptions, no, we're not. At the beginning of Medicare, a number of community clinics were set up around the province for all sorts of political reasons, and the model was and is reasonably successful, but it has not become the norm. So when physicians say, I'm burnt out, I can't do this anymore, part of it is self-inflicted. I mean, physicians haven't said, we should go all in on nurse practitioners because there's 50 years of evidence that shows that they can do 90% of what we can do. It's less expensive to train them. They could take a lot of the workload. You can train a nurse who is already, for example, practicing in a rural community and therefore has roots there and say, well, let's pay that nurse for 2 years to become a nurse practitioner, and then you have, quote unquote, there's your family doctor for the next 20 years. And they're going to stay there. They didn't come here from Nigeria not knowing what the winter was like and not having anyone from their country within 50 miles of them, and then they just can't wait to get out of there, as the mayor said. There are structural solutions to the things that physicians complain about. So yes, there are some things that have happened that they're not responsible for, but there are some things that they have actually resisted doing.
Stephen, I think the one thing that's interesting about this is you mentioned the 20 years and knowing this was coming. I think of the baby boomer generation, and I think of how that population swelled and grew and through all kinds of civilization needed to be accommodated because there were just more of them. Why didn't we think that hospitals and long-term care would also need to change to accommodate that huge segment of the population?
Well, we did. And you can, if you read every health report written in the last 30 or 40 years, they all say the same thing. This is going to come. We need to modernize the workforce. We need to get the division of labor better, make it more efficient, make sure that everyone's working to the top of scope of practice. We need to organize primary care in clinics. In rural areas, it will be difficult, but in rural areas, again, why do physicians in rural areas burn out? Because they have often solo practices. They are literally on call one way or another, 24/7, 365. It's not sustainable. So maybe instead of each community saying we want a doctor, you have to face reality. You need a population base to support a clinic with 3 primary care providers at least, and maybe some others. So if one leaves, you're not left high and dry. They can all go and get some continuing education and take vacations without the community being left holding the bag. This is how you would organize if you wanted a consistent, sustainable practice. And it's no different in the cities. I mean, the cities, it's a different type of problems, but still, you have some doctors literally who have, and they're full-time, some have a full-time roster with 500 patients and others have a full-time roster with 2,500 patients. Well, what's the difference? How does one organize the practice compared to another? Well, there's no systematic effort to understand this and to get to the bottom of it. Nothing should be done to any profession. This all has to be co-designed. Everybody has to be heard, but there has to be some collective responsibility for solving collective problems. Right now, people organize their practice and say, I'm not responsible for the system. I can only do what I can do. I will serve the patients I can serve. This is how I've practiced. This is how I'm going to do it. I got to keep myself sane doing it. And some people say, I can't do it anymore. Other people can say, yeah, I can do it, or I'll hire a practice nurse. Again, it's not that anyone doesn't want to do well. It's that nobody thinks like a system, so it doesn't behave like a system.
Okay. I want to bring in our next guest because it's already 1:45. I feel like we could probably talk about this all afternoon, Stephen, but unfortunately we have an hour. So one of the things we haven't talked about yet, but I've mentioned, is the urgent care center temporarily closing down last weekend. It is not the first time that the urgent care center has had to close early in Regina. Its intention was to take some of the pressure off the emergency rooms in Regina that were at times overflowing. Interestingly, though, the urgent care center closed the weekend of the Country Thunder Festival, which is a time that things can be a little crazy in Regina. Jared Clark is the NDP MLA for Regina Wall Shakers. He joins us on the line now. He's been listening in. Hi, Jared.
Hey, Sam. Good to be with you.
I have not noticed the number of news releases that the NDP has put into my inbox over the last number of weeks related to healthcare. What do you make of the current state of the system?
Oh, that's a great question, and it's one that we hear from citizens across this province on a regular basis. In short, our healthcare system is in trouble. It's in crisis. Whether it's folks in Regina trying to get to the urgent care center, and I was there on Saturday afternoon when it was closed and watched people come up to the door and see the sign on the door telling them that it was closed and they had to go find care somewhere else, or out in Kipling where, ERs are closed for days on end. And, you could go on and on as you and Mr. Lewis have been talking about for the last half an hour. But what it comes down to, I think, and the thing that we need to stay focused on is that the services that Saskatchewan people need in terms of delivering health care, for anything from a common cold to a chronic disease to cancer, healthcare needs to be there for people. And right now, as the shadow minister for rural and remote health on our team, my inbox and my phone is constantly ringing and filled up with issues from folks from across this province.
Jared, it is your job to be the opposition, to be critical, to hold the government to account. But I think in a time where the conversation Stephen and I have been having is that everybody needs to take a little bit of responsibility for what's going on. Have you been having conversations, whether it be with the health minister, who, by the way, we did ask to speak with today, and the Ministry of Health told us they could not accommodate the request, but are you having conversations with the government? Are you trying to talk with teams? Are you trying to work on solutions?
Oh, absolutely. Our team is very solution focused. Obviously, part of our job is to hold the government to account, to point out things and issues that we see and hear from people in this province, but definitely talking about solutions. And I think we've been very propositional in terms of what we proposed. I mean, one of the things that we've talked about for a long time since I've been an MLA is making sure that we're taking care of healthcare workers. Making sure that those people who are taking care of us in the hospital or in the doctor's office are okay, right? And that goes, as simple as simply respecting them and inviting frontline healthcare workers to the table to be part of the solutions to change the system and to improve the system that you have already been talking about today. I mean, it's something as simple as, healthcare workers in this province some of them have gone 3 years without a contract right now. That's crazy to me that people are not, that healthcare workers don't have a contract signed. So there's a lot of things that we've proposed. The Grow Your Own strategy, where communities, and I mean, Mr. Lewis talked about this already, where in small towns, in communities where people want to maybe upskill from a registered nurse to a nurse practitioner, those people are going to stay in those communities because their roots are there and they want to be in that community. Let's upskill them. We propose that kind of a solution. I could go on, Sam, but I'm going to stop and let you ask another question.
Well, I was going to ask, I understand that signing a contract would be respectful, but it doesn't address shortages. It doesn't address hours of operation. It doesn't address the fact that so many people in this province rely on walk-in clinics to see a doctor because they don't have a family physician that's regular. What concrete step, what's the first thing that comes to mind for you of if we did this, we would see some stabilization?
Well, I think the big issue is retaining the healthcare workers that we have. In so many of these instances where healthcare facilities are closing, from Kipling to Shellbrook to the urgent care center in Regina, it's about short staffing. And it's not just about the fact that we don't have enough staff in those facilities because they're leaving early or they're leaving healthcare entirely or they're retiring or they're moving to other provinces. We've heard all of those things. But it's the ones who are still doing the job, who are trying to keep the ship afloat, who are burning out.
What do you make of Mr. Lewis's assertion that primary care should be taken on by the SHA?
I think primary care is a key issue to stabilizing the healthcare system. You think of how this compounds. So if you're I got an email right before the election from a constituent. She was a single mom with a kid who has a chronic disease. She had 3 doctors in the last 2 years, family doctors, and didn't have a doctor to see anymore. That doctor had left. And so they were orphaned patients. And what's her options now to deal with her child's medical issues? She either goes to a walk-in clinic if that's full, like you got to get there pretty early in the day before they close the door, or you go to the emergency room. So now she's going to the ER to have her medical needs for her child with a chronic disease that could be easily dealt with by a nurse practitioner or a family doctor. And so now she's sitting in the ER for hours, and more people are sitting in the ER. It's not an efficient way to use healthcare dollars. That's not the greatest place for them to be in terms of the cost. So that compounds. Now you have all these people in the emergency rooms. You can't people can't get to the next level or to ALC beds and move throughout the hospital system. So it's just like, I think primary care is fundamental, and that needs to be addressed to help stabilize the healthcare system in this province. Absolutely.
When you say address, do you mean you agree that it should become part of the health authority?
I think that's certainly an option that we should be looking at. We want to be, as I said at the beginning here, this is about ensuring that mom with a child who's under 5 years old can get the care that she needs and that they need. They shouldn't have to be emailing their MLA as a last resort to hope that I can help with finding a solution for them so that that child can get the care that they need. And so absolutely, we should be looking at all of these approaches. We should be listening to healthcare workers from everywhere from cooks at long-term care, continuing care aides, to doctors, to nurses, to nurse practitioners, all across the board. Having those folks at the table, working together, and, coming up with a system that works.
I'm curious, Jared, and I do plan to ask Mr. Lewis this. Do you have a family doctor?
I do. So I am actually lucky. I'm a patient at the Regina Community Clinic. And so I see firsthand how beneficial the community clinic structure is. I can tell you, Sam, that in the last, 5 years, my doctor, and I'll tell you, because I was a patient at the community clinic, I wasn't orphaned. They hired another doctor, and I was moved on to that doctor's list of patients. And so I didn't have to scrounge around and find new doctors, because we know that the Saskatchewan Health Authority is not posting publicly doctors who are taking on new patients. And so, it's really challenging. I was in Yorkton a few weeks ago, and people who lost their family doctor had to phone in at 9 a.m. every morning to try and get on the list. It took people 2 months, 3 months of phoning every day at 9 o'clock to get on the doctor's, onto the doctor's patient list. This is the situation. But I think the community clinic model, when I go in there's a lab tech there so they can draw my blood. There's x-ray in the building. There's nurse practitioners and nurses in the building so I can get shots or whatever. I can see a doctor. There's a pharmacy right there. It's a one-stop shop to go in. The doctors, there's a whole team of them, so they can cover for each other. They can have a good work-life balance. There's a lot of positives to these, and so this solution. And I think there are solutions. As you've canvassed today, there's no silver bullet here. There's a lot of issues in healthcare, but we need a government that's actually going to sit down, talk to frontline healthcare workers, and work together to find solutions. And unfortunately, that's not happening right now.
Okay. Jared, thanks so much for giving us some clarity from the opposition side of things. We'll talk to you. I'm sure we'll talk to you again soon.
My pleasure. Thanks, Sam.
No problem. That's Jared Clark. He's the NDP MLA for Regina Wells Shakers and the critic for rural and remote health. We did ask the Ministry of Health to speak with Minister Jeremy Cockrell or another Ministry Health representative to join the conversation, and the ministry told us they could not accommodate that request. I want to go back to Stephen Lewis. Stephen, we only have 5 minutes left in the show. Right. I know we could go longer. Do you have a family doctor?
Well, I live in Vancouver now, and through dumb luck, yes. Found just literally dumb luck. My partner called up there was a window that said this doctor is taking patients. We went, go and audition. And my pitch to him was, the good news is I'm a healthy old man and I hope never to see you. And he thought that was good. And so I've never seen him, but I know I can. So, yeah. But it's, again, this is Vancouver, right? Vancouver has zillions of physicians.
Yes.
But there are lots of unattached patients. So this is not a numbers game. This is an organizational game.
Okay. So what next? What do we do? I know we didn't even get into the physician's report, and I don't feel like 4 minutes is enough time. But where do we go from here? The legislature does not come back to sit until October, so we have some time. Politicians are meeting with constituents. We know that healthcare workers are looking for a contract in some cases. What do we do between now and October 22nd?
Well, I don't think you can expect anything to be done that's different. This is not a patchwork. We can get the duct tape out and fix this baby. This is major structural reform. And I know we haven't got the time to talk about the Regina report, but every person in the province should read that report. It is, I've read a zillion, far too many health reports, and I've written far too many. This is the most shocking thing I've ever read.
Tell me more. Tell me why.
The litany of rot that is in that hospital culture, from everything from nobody manages anybody, those who try to do it are vilified by their colleagues. There are phrases in the report like, too many physicians seem to have lost the plot of why we're here. There are statements like, the financial interests of physicians seem to have trumped their obligations to the public in fulfilling this social contract. There are reports of physician groups freezing out new recruits to protect their volume of service, despite the waiting lists growing. It's the most damning thing I've ever read. And my take on it is, yeah, this looks bad on Regina, but don't think it doesn't exist in every other community. It's just that they looked harder, and now it's out in the open. If that isn't a recipe for everybody to take a step back and think we need serious changes in how we organize and manage this system, and we need to fix this, there will be nothing done in the next 3 months that is going to make this substantially better. It might get better in the odd community that gets lucky and finds a new recruit. That problem will recur in 2 years. But unfortunately, there's no short-term fixes here.
Well, on that rosy ending, Stephen, thank you so much. I always learn so much when I talk to you, and you've definitely helped put some of this into perspective. I have no idea how they're going to fix this, but hopefully the powers that be are also listening, and maybe you gave them some good ideas.
I hope so, and I don't have a monopoly of truth here, but I think the one thing we know for sure is we cannot keep doing what we've been doing and expecting it to get better on its own.